At Stockton San Joaquin General Hospital and will be giving us an overview on sutures. So I'm going to hand it over to you.
Okay, thank you, Kayla. So I'm going to start sharing my screen. Hi, everybody. I'm Dr. Castellanos. I'm part of the Family Medicine Residency Program here at San Joaquin General Hospital. And today I'm more than pleased to share with you some knowledge about, it's just a quick overview about suturing. And let me see, how do I share this? Okay. Okay. Can everybody see my screen? Or
Yes.
okay. Okay. So we're gonna start right now. It's just gonna take a couple of minutes. It's just gonna be really basic information, but I think it's really important for you to have like a basic understanding of what's suturing. Like I said, I'm one of the family medicine residents here at San Joaquin General Hospital. And what are the guidelines when we think about a surgical wound? We have to closure it. So for that, we have two things on consideration: the adequate debridement and hemostasis. Because if the tissue that we're trying to closure keeps like bleeding and the closure is not properly done, the even though you close it with the perfect stitch, it's not gonna heal properly. So the goal is do not harm. So once you're trying to suture, you are trying to do the less traumatic as possible. And once you try to close the skin, you have to align it like back to like more back to normal as more as acutely anatomical possible. So for that, you have to take in consideration the angle of incision. It has to be perpendicular to the skin surface or slightly undermined. You have to consider the area of the body for vascularity and tension of the wound, because it's not the same to place a stitch on the, let's say, on the head than place a stitch on the hand, because the skin is different depending on what part of the body, and that's because of the different layers that the skin has, and that's going to take into account when we take when we take into account what kind of suture, how long are we going to place them, and uh, different let's say different kind of needles that we use during sutures. And it's important that when you are closing the incision, do not leave dead space, because that could leave some that could lead to infection, or what we call like a fluid collection. It keeps draining, the wound is going to be really oozing, and we don't want that. Okay, so before we start, we have to prepare everything, because you have to get everything ready. Otherwise, you're going to be like, oh, I forgot my gloves. Oh, I forgot this. So make sure you have all the instruments that you're going to need, and think ahead like, okay, so I have this type of wound. What do I need? What type of needle do I need? How long is it going to stay? Is the patient in pain? So what kind of anesthetic am I going to apply? So think ahead. So take some time, like tell the patient, yeah, it's hurting. We're going to work on your suture, on putting some stitches. Patient can be a little bit anxious, but if you let the patient know ahead of time what you're going to do, he's going to calm down, and that will make everything easier. So, like I said, prepare all your instruments, prepare what local anesthetic, and if you, and we're gonna go through like what's the basic for that. So the instruments, basically all you need is this. The forceps is like what we have here is gonna help you like grab the borders of the skin. The hemostat, that you can use it as a needle holder in case you don't have one. And the scissors, as you can notice, the scissors are not like sharply pointed, because what we want is to protect the skin and do not harm. You got to remember that. And for suture scissors, the end of the scissors, as you can see, are kind of curved, because that makes it easier to grab the end of the knot and just cut it like under it once we're removing the stitches. So like I said, you have to think about the materials. We have two type of sutures. We have absorbables and non-absorbables. For the nature of this presentation, we're gonna go with the non-absorbables, because we're gonna focus on closing skin. But if we are doing like something more complicated, like surgeries, C-section, and other type of surgeries, we're gonna go for absorbables. But non-absorbables, basically what we use, and it's commonly used, is surgical silk. Is the That one is black mostly. We also use nylon and we use proline. Okay, so now that you thought like, okay, I need non-absorbables, but what kind of needle, what type of needle do you need? So all the needles are numbered from 2 to 6, even there are some 8s. There are different type of needles, but the curious thing about the needles is that the higher the number, the smaller the needle. And that makes sense, because let's say for face, we are gonna need a needle that it's 5, 5, 5 or 6 0. That's a bigger number than 2 0 or 3 0 that we will use in the back. So we are going to use the smaller needle for the face, for the eyes, for the eyelids, something that is really delicate for the mucosa, but something that the skin that you know is really thick, let's say the feet, back, extremities, you can use 2 to 3. Okay, this is the kind of aesthetics. So with this, I'm not worried about like you have to memorize everything. It's just like you have to understand that the patient is in pain. So analgesia is something that plays
Dr. Castellano, I don't think we're hearing you right now. Can you double check your mic? Hold on, everyone. We're just getting through some technical difficulties. 1 second. There we go. Go ahead and talk.
not. So I'm gonna try to explain you, it's kind of hard to do it through Zoom. I'm gonna play a video after so you can understand how technique is done. So we do with the instrument. So let's say you place the stitch here and then you go out this way. So you have the suture tense here. You grab your needle holder and you place it here. So you're gonna like go, let's say on the right, you're gonna like circle the instrument, then you're gonna grab the end of the other suture and you're gonna do the knot. Then if you did it on the right, now you have to do it the opposite way because you're trying to make like a square like this. So it goes from one way to the other. So if you did right, now you do left and you close it, and that's basically it. That's the most simple one. And if you want to do like the surgeons knot, what you do is instead of doing one round, going one round around the needle holder, you do it twice. You do it twice from whatever direction you want, and then you pull it, and then you do another one just to close it. And as you can see, this one's different because you did it twice here, and then you did one extra to close it. And this one is just one, and let's say on the right, one on the left. And when you're holding the needle, you don't grab it by the end because you're gonna like destroy the needle and it's gonna lose its sharpness. So you usually grab it by the end of the, like 2/3, we call it. So you do it perpendicular to the skin, 90 degrees, and you actually have to imagine that you have 1 centimeter between each stitch that you're gonna place and 1 centimeter from the border of the wound. So here we have 2 centimeters because you have one here, one this way, one this way. So it's pretty like accurate. And in this image, I have what I was explaining earlier, that if you don't close properly the wound, it's gonna form dead space. And this is like a playground for bacteria. Everything's gonna grow there and the wound is gonna become really oozy. So I'm gonna try to go through 3 techniques. Those are the basic ones. And I think that those are gonna be the most helpful for you guys. The first one is each technique has their own like advantage, and we're gonna go through them. So the first one is the simple interrupted. This is the most basic one, and you can use it for biopsies, uh, like injuries that do not require a lot of uh, complicated technique. It's also the basic suture. And the advantage of this one is that you only need a few sutures and it's easy to be removed. So when you are doing suturing, you have to go by what we call the rule of halves. So let's say you have this one here. So the rule of halves says you go by the middle. So you're gonna start doing your first stitch on the middle of the wound. That's gonna help the tension of the wound become less tighter, I would say. And this is the first stitch. So now you're wondering, okay, I'm done with this one. Where do I place the next stitch? So the next stitch, you can do it on the right, 1 centimeter apart from the first one in the middle, and then the other one, you're gonna do it 1 centimeter on the opposite side. So you go that way. And here's another figure that shows what I was explaining you earlier. First suture goes in the middle, Then you have the second suture, third suture, and you go like this. And here's another view from the simple interrupted from a different way. And at the end, you're gonna have something like this. So there's another one that continues. I don't know if you have seen them. This one is pretty easier. It's even easier than the other one. The advantage of this one is that you're gonna finish your closure faster, but you gotta be careful because if you cut one part of the suture, the entire wound is gonna reopen. So you actually just go one way to another, one way to another, one way to another. And then we have a special one that we call the mattress. So for the mattress, we have two types. We have the horizontal and the vertical. The mattress, we usually do them when the borders of the skin are really like far away or the edges, there's a lot of tension. So this one is gonna help us get those edges really close. So let's say this one. So you start here and you go 1 centimeter away from the other edge, and then you're gonna go 1 centimeter from the last stitch, and then you're gonna go back 1 centimeter. And then you're gonna do this kind of like mattress is like a horizontal. So from another view, it's gonna look like this. So the advantage of this one is, like I said, closes wound edges under high tension, and it's great for hemostasis. We usually do them when there's a really bleedy wound, but otherwise it's kind of, you will do the interrupted. And the vertical is the same. You will do it, let's say, in some areas that have a lot of tension, like the elbow, like the knee. And this view is better. What you do is you go like this, and then you come out here, you come out here, and then you come up here. It's kind of hard to explain through like Zoom. It's better to do it like a kind of like a workshop, but I have a video after. So once you're done, after the sutures are placed, you clean the wound and you can apply a small amount of antibiotic to cover the wound and place some dressing. And something that you have to take into consideration is the tetanus vaccine, because there are two types of wounds, what we call clean and what we call dirty. What makes a wound clean? To have a wound that is clean is really difficult because it has to be mostly in the operation room. If it's dirty, which are the most common ones, because there's going to be soil, there's going to be debris in that wound, that that wound will require the tetanus vaccine. So that's something that you have to take into consideration when you're doing your suturing. And now you have to tell the patient or the person, okay, so how long am I gonna have the stitches for? That's the big question. So it depends on what area of the body is compromised, because the skin has different type of layers according to the body part. So we usually do the rule of 1 week to 10 days, because that's when I require, let's say, the extremities, the scalp, uh, what else? The hands. The only one that requires lesser time is the face, but that's because we don't want to leave the stitches for too long, because the stitches at the end, we got to remember it's a foreign body, so the body is going to react against it, and it's gonna start the inflammation, and the scarring tissue is gonna get bigger. If you notice that the wound, that the suture has any signs of pus or infection, you gotta remove it immediately, and you have to do a washout, because that tissue is dead. So you have to do a debridement, and those edges are not gonna stick together anymore if there are some signs of infection. So for the suture removal, you are gonna clean any signs of crusting or any dry blood with regular water, and that's gonna make the stitches become softer. What you're gonna do is you're gonna use your tweezers, grab the knot, and then you're gonna use the scissors that I showed you before that have the curve, and you're gonna cut under the knot. Then you're gonna pull on in the direction that keeps the wound closed, and you're gonna place a clean dressing. At the end, you have to count how many stitches you have removed according to how many the record says there were placed, and that's basically it. So right now, I'm gonna play this video that I think it was really helpful. Basic suturing video. I'm going to teach you the surgeon slot and the square knot in this video. And for practice, you can get off
We're not seeing the video.
pad, needle driver, the forceps, and some cheap sutures, as pictured here. Are you able to hear the video?
Yes, we can't see it though. You might have to stop
Okay.
sharing and then reshare.
Okay.
When you reshare, you need to click the button on the bottom to optimize for video, and click here your computer.
You share, so I'm gonna share this one, share. Okay. Welcome to the lifelong basic suturing video. I'm gonna teach you the surgeon slot and the square knot in this video. And for practice, you can get off Amazon.com the cheap suit. Can you watch the video now?
Yes.
Okay. Pad, needle driver, the forceps, and some cheap sutures, as pictured here. And before we get started, I want to show you a little demonstration on bite width and bite depth, which is how far away from the wound you're placing your needle and how deep your needle goes. So in this particular scenario, you want to use your best judgment as far as placing your needle at insertion site or your bite from the wound or incision. So for this scenario, we're going to use the green line as 1 centimeter, and 1 centimeter away from the wound means you'll go 2 centimeters deep with the needle, and that's pictured here. Now the 1 and 2 centimeters are only just a guide and only serve as the idea on how you want to insert your needle and how deep your needle should go in relation to your distance from the incision. Ideally, the tip of your needle should come up on the other side of the incision or wound at about the same distance as your other insertion site. And as you can see in this demonstration, the entry and exit point of your needle is roughly the same distance from the incision. When deciding on where to insert your needle, generally a good rule of thumb is the exact center of the wound. And again, putting this insertion and exit point at roughly the same distance from the wound itself or incision point. And after completing our first suture, we can then decide on where to put our second suture. And there's 2 ways to do this in this particular scenario. We'll want to go ahead and do it immediately left or immediately right of the first suture, keeping your bite width and bite depth the same for each suture. And then after a second suture, you can place a third and a fourth, again alternating sides and keeping the bite width and bite depth roughly the same, so your sutures look nice and even. Now again, this video is just demonstrating the single interrupted suture, which is just the basic suturing technique and the simplest suture. When doing these types of sutures, you'll generally want to keep them straight, not crooked,
and keeping the same bite width and same bite depth. So what you don't want is sutures like this. And demonstrating another wrong way to do it is having the suture length longer on one side than the other. Now getting into the real demonstration, you'll have already wanted to clean your incision or irrigated your wound prior to suturing it up. That way it reduces your risk of infection. Now, using your needle driver or your hemostats, you'll want to grab onto the needle on the posterior 1/3 on the flat area to ensure that you don't damage the needle prior to inserting it. Once it's good and comfortable, you want to take your forceps and don't pinch the skin like so. You'll want to just kind of support it while you're inserting the needle. If you pinch it too hard, you can certainly do the skin more damage. Now for your larger incisions, you may have to do 1 needle stick per side before you complete the suture, but on this small incision here, we'll just do 1 needle stick in general. Once you determine your approach, you'll need to identify where you want to insert the needle at. Just like in the demonstration, in this incision, we'll use the exact center of the incision to go 1 needle stick and go all the way to the other side with the same bite width and roughly a bite depth of double the bite width. Remembering to insert at a 90-degree angle, you'll want to supinate your wrist or turn your wrist over so that your palm turns towards the ceiling. And you'll have to do this relatively in a short and quick motion to be able to get the needle out in the right spot that you want it. Otherwise, the needle will come out too close to you and too far from the incision. Once you pull your needle out with your forceps, again, not crushing the tip of the needle, you want to pull the excess suture till you have a short end and a long end like here. And again, if you can see here, you'll have the same bite width roughly on each side of the incision. And again, this is just a general rule of thumb. So as you see, both sides are roughly the same. And here I'll just point out again that we inserted the needle at roughly the midpoint of the length of the incision. So you're same on both sides here. Now to secure this first suture, we're going to use the surgeon's knot, which is pictured first on the bottom is the 2 loops, and then complete the knot with the second one on the top, which is 1 loop. So there's 2 ties for the surgeon knot, as with any knot. So the first one we'll demonstrate here. Now, a good rule of thumb, until you become comfortable tying sutures, is placing your needle driver parallel with the incision. And after you're parallel to the incision, making sure you're inside the suture here. So we're going to loop it twice, and then turn our needle driver perpendicular to the incision and grab our small end and pull it through. And we're looping it twice and pulling to pull the incision together nice and tight. Not too tight, but this will allow the incision to stay together while you get your second loop ready. Again, we're going to loop it, and then in this time I'm not going to grab the tip of the short end, I'm going to grab in the middle, and then you'll see what happens if you don't grab the tip. So you'll have to pull it through here extra, and you don't want to do that. So just remember when grabbing the short end of the suture to grab the tip, not the middle. Alright, to complete your first interrupted suture here, you want to finish off with a square knot, which is just 1 loop towards the center there, and grab your tip, pull through, perpendicular, and then 1 more single, which is looping towards the incision, and again perpendicular, grabbing the tip, and pulling through. We completed 4 ties total, 1 2 loop, and then a single, making the surgeon's knot, and then 1 loop, and then 1 loop, making the square knot. Now since we've got our first suture done here, and pulled our knot to one side of the incision, and trimmed our excess, we can determine on where we need to place our next suture. Now here's where you have 2 options. You can certainly measure the bite width and go to the left or to the right immediately of the center, making sure that the bite width is the same. The other way you could do is split the difference. Again, just like we did the first one, we split the length of the incision, and then you can split on either side. So starting with the left, we'll do that here. Remember, going 90 degrees, holding the needle at the posterior 1/3 with your needle driver. Should be the flat part of the needle, and then pulling it through with your forceps, ensuring not to crush the tip of the needle, and making sure you're supinating your wrist properly to be able to get that needle out on the correct side and not too far away from your incision. And then again, just making sure you pull your suture material through so you have one short end and one long end. So we'll demonstrate the surgeon's knot and the square knot once again. So starting with your needle driver again, parallel to the incision, in between the sutures, go to wrap twice, and turn perpendicular, grab the tip of the short end of the suture material, and then pull in perpendicular across the incision, again making sure that's not too tight. Then we want to go parallel again, wrap towards the incision, grab the tip of the short, and then pull through perpendicular, completing the surgeon's knot. So again, after the surgeon's knot, we're going to do the square knot. So again, start parallel, do one loop this time, grab the tip and then pull, parallel, wrap one loop, grab the tip and then pull. So that completes the square knot, which completes this single interrupted suture here, once again. Pulling the knot to the same side as the other knot for the suture. And for the right side, you can split the length again from the middle suture to the end of the incision, just like I did on the left. And then repeat that process into the...
So I want to pause the video here. And this is what happens when you don't follow the 1 centimeter by 1 centimeter rule. This is obviously more than 1 centimeter. So you have this part of the wound that is not closed. So this is not gonna, these edges are not gonna stick together. This is gonna keep oozing. This is a major site for infection. So this is mostly because of education purposes, but the stitch should have gone like here in between these two to make it 1 centimeter, and that will have closed perfectly the wound. So in a real patient, that's what would you do. And other things that you have to make sure, just for purposes, as aesthetically purposes, that all the knots are on the same side. So if you end up here, let's say on the left side, all the knots are gonna be here. You cannot go one knot here, one knot here, one knot here, because that's not correct. And that's gonna make the removal of stitches even more difficult. And
making sure to fill the gaps by placing sutures equally distanced from each other to close the incision completely.
And that's it.
Thank you so much for that. I would like to open it up if you would like to have any questions and answers.
Yeah, sure.
Would anybody like to ask a question at this time?
I have a question.
Yeah.
So in the kind of patient population that we're going to be facing, if we have an athlete that sustains a laceration that requires sutures, how soon should we get them to an emergency department to get sutured for optimal healing of that wound?
Well, first of all, it depends on how critical is the wound. Let's say if it's a 2 by 2 or let's say 5 centimeters max, depending on the location. The American Family Medicine Guideline says that you can even wait up to 12 hours to require to go and get a stitch, and that wouldn't affect the scarring process. The good thing to know is, let's say you have an athlete who just got a wound. The first thing that you have to do is hemostasis. So you have to grab a clean dressing and press the wound to stop the bleeding. There's no, and then you can do some cleaning. Just run some water on that wound, and that's going to prevent the infections. Then you can just keep the dressing, leave it with some pressure, and take it to the ED if you don't have the kit nearby, and you can apply some stitches. But you can wait up to 12 hours It's not the ideal, but it's that's kind of like the limit. Okay.
Thank you.
Does anybody else have any other questions? I just wanted to ask, so say, I know Carly just asked you that question, but what if the stitches open up? Do you still have that same 12 hours, or would you rather us get the patient to the ED as soon as possible, or make an emergency visit?
Well, that's something that's different because once you place the stitches, the process of scarring is going to start. So the tissue is going to become like, I don't know if you have noticed, there's like a pink, whitish layer on top of like your wounds. So
Mhm.
that's like the skin is regenerating. So at that point, once you place a stitch and it opens, you cannot do another stitch because there's a top layer of new cells that are growing. So in that case, you can do a debridement, and you have to do a washout and remove that layer of new cells that are growing, that whitish layer, and then let the cells that are at the bottom close and place another stitches. But if there's an infection, there's no need to place more stitches because what you're gonna do is you're gonna create an abscess.
Mhm.
So if there's an infection, just let it be open and it's gonna drain. You give some antibiotics and it's gonna close by its own. Probably not gonna be like the most perfect looking scar, but it is what it is. It's one of the complications of not doing proper suturing or not doing it on a time frame matter.
Right. Thank you for that.
Okay.
Did anyone else have any questions?
I have one. The pros and cons of suturing versus steri-stripping them.
Okay. So you can do steri strip. There are some wounds that you don't even have to suture. It all depends on the length of the wound, and you can place the steri strips. But the benefit of the steri strips is that it's gonna leave some space for draining. At the end, it's gonna be the same as long as you close the edges and you do like a proper washout of the wound. It's like placing stitches, but without the stitches. So if you do it properly, it's gonna be the same result.
Because I've done a few and send them steri-stripped and then sent to the ED, and the ED looks at them and go, yep, you're good.
Go home.
Yeah.
Yeah. Yeah, it's all about doing it properly the first try, and there's no need to even touch it. Like, if it's correctly done, that's it.
Yeah. Our problem with steri-strips is the returning athletes and sweating, trying to keep them on. The steri-strips on can be difficult sometimes.
Yeah, or if it's oozing a lot, the stir strips are gonna like uh, are gonna like they're not gonna stick anymore. So you have to replace them. But that like putting a new one, replacing it, that process is not gonna help the tissue to scar properly. In that case, you will rather do stitches that you know they're gonna stay there. But if not, you can do stir strips.
So if we have a laceration during an athletic contest, not too big, we can control the bleeding. We can put a sterile gauze on there, cover them with some kind of tape, and they can safely finish the contest and go get sutures afterwards. Is that correct?
As in continue playing, I wouldn't. I mean, if the wound is not that big, he can continue going, but you gotta remember there's gonna be pain and there's a chance that he might have another injury and that wound is gonna become like, if it was like really small, it's gonna become bigger. If you gotta also, depending on the place, because if it's a wound over like a closed area where a tendon is,
Yeah,
that might have been compromised. So I wouldn't recommend that. But let's say if
Yeah.
just a wound on the forearm, a wound on the back, you can safely keep playing. But if it's a wound on the knee, on the ankle, on the elbow, then you gotta get it checked. And depending
Okay.
on the depth of the wound.
Yeah. Okay. That's why for us guys, it's really nice at competitions when there's a physician there and they can make that decision.
Yeah, I mean, it's not like we want the team to lose a valuable player.
Right,
It's just like sometimes you gotta do what you gotta do.
right.
You
Yeah.
have to
I mean, that's the same for us. I mean, we have to make, I mean, we work with these players every day. We want them to win, we want them to do well, but sometimes it's just telling you like, hey, this person needs to be done and out of the contest for today. Yeah.
Yeah.
Have you used Dermabond before to like seal wounds?
Yeah, we do Dermabond at the hospital, but that's we usually do them when like there's an sterile area and we do like a good cleaning, because the Dermabond is just like glue. So it just stick the edges. It's the same. You can even do Dermabond and then place the strips on top of them, and that gives really nice results. We usually do them for like the C-section scarring, and there's no like the outcomes have been pretty good with that one. It's kind of like the same as in doing stitches. The one that we are trying to get rid of is like staples, because staples are more like a abrasive to the tissue, and we would rather do Dermabond, but it has to be under like a really clean, sharp, defined edges wound. If it's something like someone fell off and the edges are really like are not like really sharp, I wouldn't recommend Dermabond.
Thank you.
Is there anyone else that has any other questions? We have about maybe 13 minutes left. I had a quick question again.
Yeah.
So just, I know some of like our patients or athletes, they're worried about keloiding. What advice would you give them for that?
Oh, for keloids. Um, for keloids, we don't know. Like, we cannot tell, okay, this patient's gonna have a keloid or not. It mostly depends. Some studies have shown that it's based on the race. African Americans are more susceptible to develop a keloid. Also, if it runs in the family, but to develop a keloid, it could be a wound that's super clean in the OR and it's gonna develop a keloid. Others are like on the field and it's gonna develop a keloid. It's about how your body is gonna do the scarring process. It's not something that we can determine. After you develop the keloid, there are some treatments, but sometimes the treatment is even worse than the problem. So the keloid becomes bigger. It all depends on the size and how uncomfortable the patient is. Otherwise, we just leave them there.
Makes sense. Thank you.
Yeah.
We have time for one more question. If not, then I'm going to close it out. Anybody else? Okay, well, thank you so much for your time. I've learned so much. We appreciate you for coming. And I hope you have a great night. Thank you everyone for coming.
Thank you
Thank
for.
you. We appreciate it.
Thank you, doctor.
Thank you so much for your time.
Anytime.
Have a good night.
You too. Bye.
Dr. Castellanos, thank you again.